everyone. Today I'm here with the another lecture in our IPL series of 30 questions in 30 minutes. So today's topic will be normal labor. In this series, me and my colleague Dr. Fareen, we are trying to complete maximum of obs and gynae questions that have been asked in previous 5 years in minimum time. So let's start with our new topic, normal labor. So first of all, definition. What is labor? So what is labor is all the changes which are occurring in the presenting part. Now presenting part can be head, it can be breech, whatever is your presenting part. All the changes that are occurring in the presenting part while it is traversing through the pelvic canal, that is the mechanism of labor. Okay. Now the steps of the cardinal movements, the changes that are occurring in presenting part when it is skiff-lick presentation, which is most common, that has been asked many times. Even this year NEET also the cardinal movements have been asked. Now you do not need mnemonic for this because there will be too many mnemonics. You will need mnemonic to remember your mnemonics. So somewhere use your basic sense. Like here, you do not need to rectify these cardinal movements. So first step is the engagement. Engagement is when your biparietal diameter crosses your pelvic inlet, that is the engagement. So after engagement, once the engagement has done, the biparietal diameter has crossed the inlet, next step is descent. Descent is not the next step. It's a step which is constantly occurring. It is the prerequisite for delivery. Descent has to occur continuously. Okay. So once the engagement has occurred, it means labor has started. Descent is constantly occurring. So next step is descent. As during the descent, the head encounters the pelvic floor, that is the levator ani, the flexion occurs. The flexion of the head occurs as soon as it encounters the levator ani. So next step is flexion of the head. Now head has flexed and it has reached the pelvic cavity. So inlet is this. The longest diameter is transverse, whereas the cavity is like this. AP diameter is the longest. So now what will head do? It will internally rotate. So internal rotation will occur now at the cavity so that occiput comes behind the pubic symphysis. Now once the internal rotation has occurred, what happened? Crowning. Crowning will occur, and once the crowning has been done means with every contraction, head try to come out, but as contraction goes back, it will not recede. That is crowning. And once the crowning is done, it's time for head to deliver. So head will deliver by extension. Head was in flexion because of the muscles, muscle resistance. As soon as it comes out, muscle resistance goes, head delivers by extension. Now, once head has delivered, during the internal rotation, there was a twisting in the neck. So when head is delivered, that untwisting of neck occurs, and which is called as restitution. Restitution is that untwisting of neck occurs and head moves back to the previous direction. When now the shoulders are in the cavity. Now shoulders have to move into these AP diameter. So when shoulders move in this AP diameter, you see the rotation of the head called as external rotation. External rotation is nothing but telling you that now the shoulder has come into AP diameter. Now the shoulders have moved in the same diameter. Now they will deliver anterior shoulder first, followed by posterior, and the delivery is complete. Okay. So these are the steps, easy to remember. Now next common question that has been asked in NEET is the most common position which is there at time of labor. So when head enters the pelvis, the most common position it takes is left occipitotransverse. So this is left, this is right. Left occipitotransverse in the inlet. So inlet is like this. Transverse diameter is the longest. So occiput tries to remain is this diameter. Occiput tries to remain in transverse diameter, that too on left side, because on right side there is sigmoid colon. Okay. So that is why left occipitotransverse is the most common position. Now for knowing next common position, just move anti-clockwise. Next common is left occipito-anterior. Next common is right occipito-anterior. So left occipito-anterior is more common than right occipito-anterior. In the posterior positions, the most common is your right occipito-posterior. Okay. And least common is left occipito-posterior is your least common. So the questions have been asked on both the most common and the least common positions of fetal head. Okay. Yeah. Now, there was a question on basically how the pain is transmitted during labor. The question was asked in INICET 2022. Okay, so you should know the labor pain basically is caused by uterine contraction and the stretching of the cervical dilation. So the initial stage, the first stage of labor, the basic cause of pain is uterine contraction. It is transmitted through sympathetic spinal nerves T10L1. T10L1 basically are the one which are transmitting these first phase of labor pains. In the second stage, when the cervix is fully dilated, now the main cause of pain is the perineal stretching. So now the pain in second stage is being transmitted by S2, S4. the pudendal nerve and the sacral nerve. Okay, so in first stage T10 L1, in second stage S2 S4. Now why the question was asked? What was the clinical implication? Hear it. So in first stage, if you are trying to give some pain management, you are giving epidural, you want to cover the nerve fibers which are transmitting pain from uterine contractions and both the cervical dilation. So you will make a block at T10S5. So if you are giving epidural in first stage of labor, this is the level T10S5. You want to cover both this T10L1 and the late stages of labor pain. You want to cover both. That is why this is the level of your block. Now suppose a patient is fully dilated, but you want to apply instrument. Now you want to give her pain relief. Okay, so she is in second stage, very advanced in labor. For the instrumental delivery, you just need to block S2, S4. So where do you need to give the block? At pudendal nerve. So for instrumental delivery, you don't need to specially put the epidural. If epidural has been given, that will cover, no doubt. But if you specifically want to give her pain management, some method during instrumental delivery, pudendal block is the best because it will cover S2, S4. Now suppose if patient is undergoing cesarean, now what area you will cover? Now nothing S2, S4 cervical dilatation will not happen. Patient will not deliver through cervix, so you need not to cover these nerves. You will give a block at T4, S1 level. So that is the level at which block is given for cesarean, and that is the clinical implication. That is why it was asked in INICET. Okay, yeah. So now we have discussed the general facts about the labor. Let's start with the management. First stage, you know the first stage, from painful labor pains to full dilatation is first stage. Latent phase is till 6 cm. Beyond that is active phase. How do you manage? So oral intake in a patient who is in labor in first stage, clear liquids is given. Important is fetal monitoring. How do you monitor fetal heart? 30 minutes for low risk, 15 minutes for high risk women. That's how you monitor the heart rate. And IV fluids is given if the labor is prolonged. We will discuss in a while what is prolonged latent phase and active phase. Since I have written, you can read it. Prolonged latent phase is more than 20 hours in primary and more than 14 hours in multi. Isn't important? Yes. It was asked in NEET 2019. Exact numbers. More than 20 hours in primary, more than 14 hours in multi is the prolonged labor. Okay. How do you manage? We'll discuss later. Now patient has come to you in labor. You will do what? Cervical assessment. So for cervical assessment, we have a score to see how favorable the cervix is for delivery. If you want to augment the labor, which method you will use will depend on the Bishop score. So modified Bishop score question has been asked. In NEET, question was asked, what are the variables used in modified Bishop score? And the proper calculation of Bishop score was asked in INICET 2021. Okay, so you need to know how to calculate. So basically 5 variables are used. 4 are of cervix and 5th is fetal head station. You can use a mnemonic. So mnemonic is LCD PlayStation. So LCD PlayStation is length of cervix, cervical consistency, dilation, then position of cervix, and in the last fetal head station. That is what it stands for. So lesser is the length, better is the score. Okay, now score is divided into 0, 1, 2, 3. How will you go? 0. So you have to remember, you can remember consistency. Soft it is, better is the score. Firm cervix, bad score. Similarly, position, anterior cervix, good score. Posterior cervix, bad score, 0. Length, you can remember that it is even number. You have to go even number. So length, when it is 4 centimeters, it's bad, it's 0. So you will start with minimum number. Less than 1 centimeter is a good score. Okay, maximum score. Less than 1, 1 to 2, 2 to 4, 4. All the even numbers. 1, 1 to 2, 2 to 4, more than 4. Except 1, then even number jumps. That is how you remember. Whereas dilation is a continuous number. More is the dilation, better is the. You start with 0. So for 0 dilatation, 0 score. And now continuous variables. 0, 1 to 2, 3 to 4, 4 to 5. Okay. So this is how it goes. 0, 1 to 2, 3 to 4, more than 5 is dilation. Station. Now question has been asked in NEET on the station. What do you mean by fetal station? Fetal station is telling you how far the presenting part is from the ischial spine. Ischial spine is your 0 station. Anything above ischial spine is negative, -1, -2, -3. Anything below ischial spine is +1, 1, 2, 3. 1 means 1 centimeter. 2 means 2 centimeter. So plus means 2 centimeter below ischial spine. If number is in minus and higher the number, bad is the score. So -3 and above is a bad score. Then -2 is better. -1 to 0 and +1, +2 are the best score. So you have to memorize this table because calculation has come. One important thing is that if the patient is nulliparous and if the patient has got PPROM And if the patient is post-dated matlab more than 40 weeks. Post-term means more than 42 weeks. If she is post-dated, you will subtract -1. Similarly, for a patient who has delivered vaginally previously and who has been pre-eclampsia, you will add 1. You will add 1 for each delivery to the score. So this is important, you have to remember that. In the question which was asked, the patient was post-dated. They specially mentioned a post-dated patient. To see whether you know, you have to subtract 1. So score more than 6 is good and less than 6 is a bad score. So this is all about Bishop score, the variables and how do you have to calculate. So score better than 6 is a good score. Okay. Next, management. So first stage we have seen is a very general management. Management of second stage is important. So management of second stage in detail was asked in 2021 INICET. In INICET 2021, management of second stage of labor was asked. Now, so let's see what is second stage. When there has been full dilatation to delivery of the baby is second stage. What do you have to do? Position can be of the maternal choice. It doesn't necessarily need to be lithotomy. It can be all 4 position. It can be squatting position. It can be lying down position. Okay. Pushing is allowed, but only when cervix is fully dilated, when mother has urge to push, and during the contractions. Then only you can have pushing effect. Episiotomy is restrictive. You do not give it in every case. Episiotomy is given only when needed. Next, perineal trauma. Now, perineal trauma is something which is very unavoidable during normal delivery. So, WHO came up with 3 methods to avoid perineal trauma. They came up with a technique called as hands-on technique. They said when you deliver, you keep one hand on the vaginal introitus, you can like see here, and your left hand should flex the head. That was the problem. In the question, the option was left hand deflexing the head. No, you will not deflex. If you will deflex, the larger diameter will come out and perineal tear will occur. So with your left hand, you will flex the head. With the right hand, you will try to cover the introital area to prevent perineal trauma. This is hands-on technique. Next is warm compresses. So warm compresses is allowed during the contractions and in between the contractions also. So you put warm cloth around the perineal area, leading to softening of muscle and less of the perineal trauma. Next is perineal massage. Perineal massage is basically important in primary patient and started from the last trimester and continued during the labor. So these are the 3 steps which were devised by WHO to prevent perineal trauma. Fundal pressure is never given. It has never to be given like this. FHR monitoring, like in first stage it was 30 minutes and 15 minutes. Here it is 15 minutes in high risk, in low risk, and 5 minutes in high risk. Okay, very important. Almost all these steps were one of the option in the question when asked. Episiotomy. So since we have discussed, episiotomy is a intentional cut to the pudendum. It has to be restrictive only in certain conditions. You cut the pudendal area, like it's a breech baby, it's a shoulder dystocia, it's a macrosomic baby or a tight perineum, then only you do episiotomy. It is not a universal thing to be done. Now questions have been asked many times on episiotomy. In NEET, it was asked what are the structures cut in episiotomy. So episiotomy can be of 2 types, medial and mediolateral. Most common episiotomy given is mediolateral. It is started from introitus at a 60-degree angle of a stretched perineum. It is given when perineum is stretched due to crowning. It is given at an angle of 60 degree of a stretched perineum. So what are the structures being cut? You are cutting this muscle, bulbocavernous. You are cutting this transverse perineum, and you are cutting here puborectalis, which is levator ani. So you are cutting 3 muscles, bulbocavernous, superficial and deep transverse perineum, and levator ani. Besides that, posterior vaginal wall and subcutaneous tissue. You are not cutting muscle here, which is ischio-cavernous. You are not cutting this muscle. Okay. So that was the question asked. Which muscles you are cutting in a episiotomy? Another question was asked in NEET that in a midline episiotomy, somehow it extended backwards. So which muscle must have been cut? So if a medial episiotomy is extended backwards, which muscle must have been cut? Obviously, external anal sphincter was cut. It was again not ischio-cavernous, which was there in option. It was not paraurethral muscles. It was external anal sphincter is cut. That is why median episiotomy is always avoided. It is mediolateral which is given. Okay. This is episiotomy scissor asked in NEET exam to identify. Now, how can you identify? It already has an angle, so that you can give an angulated episiotomy. Also, one end is sharp, one is blunt, so that the end which is entering inside the vagina does not cause trauma to fetal head. So this is episiotomy scissor. Let's talk about the perineal tear. So episiotomy was an intentional cut. Perineal tear means the tear that happens unintentionally during the delivery. Now this perineal tear has been divided into 4 grades depending on how deep it is. So first is when only mucosa is involved. Second, mucosa and muscle involved. Now you can see here that episiotomy is second grade tear. Okay, though it is intentional, all the episiotomy, medial or mediolateral, are second grade tear because you are cutting both muscles and the mucosa. Then if the sphincter is involved, anal sphincter, it is grade 3, and if the rectal mucosa is involved, it is grade 4. So grade 3 and grade 4 are together called as OSIS, obstructive anal sphincter injury. Okay, this is the term for grade 3 and grade 4 perineal tear. Grade 1 tear you do not need to repair unless it is bleeding. Grade 2 you have to repair. You can repair it in labor room when the patient is conscious. Okay, you do not need to sedate the patient. Grade 3 and 4 have to be repaired in the OT because of good lightening, and patient has to be under general anesthesia, then only you can repair. Many times the question have been asked on the repair of perineal tear. 20 in NEET 2021. When do you have to repair? Immediately when you have diagnosed, you can repair, or within 24 hours. If you have missed this 24 hours, you cannot repair it for 3 months. So if a patient comes to you in OPD with a perineal tear, maybe after 10 days of delivery, you have to ask her to wait for 3 months. Why? Because the inflammation in edema is so much that if you will try repair, your surgery will result into failure. That is why you wait for 3 months. Aftercare you provide to a perineal tear patient is antibiotics are given once the repair has been done. Laxatives are given. These are not given during episiotomy. In episiotomy, you do not give antibiotics. You do not give laxatives. In perineal tear repair, you give. What about future deliveries? If patient is slightly even symptomatic during second pregnancy, or in rectal ultrasound you saw there is internal sphincter defect, patient will undergo cesarean always, right? So next is the third stage. So third stage is the stage of placental separation. So how will you manage third stage? So third stage can be managed in 2 ways. One is the expected management where you do nothing. It's hands-off method. You do nothing. No uterotonics, no placental separation you will try for. Another is active management. Now active management of third stage of labor is universally applied in everyone because it can decrease your PPH incidence by 60%. So active management is to be done universally. And what are the steps? Have been asked n number of times, as last year in NEET also, previously also. They keep changing the options and they ask you what are the steps. So WHO in 2018 has arranged its 3 steps importance wise. First is uterotonic. But important, before administering any uterotonic, you have to put your hand on uterine fundus immediately after delivery to rule out presence of any second twin. There is second twin, you cannot give the uterotonics. So you first rule out presence of any second twin and then you start with active management. First step is uterotonics. How will you rule out second twin? Just keep your hand on fundus. Immediately after delivery, the uterine fundus is at or just below the umbilicus. It means there is no other second baby in the uterus. You give uterotonics, the drug of choice is oxytocin. Oxytocin can be given IM, which is the route of choice, or IV infusion. In cesarean, IV bolus 5 units can also be given. So all can be used for prophylaxis. If oxytocin is not there, methergin. And if methergin is not there, misoprost. Misoprost acts little less, so it's the last choice. Those in NEET have been asked for prophylaxis and treatment of PPH of misoprost. So prophylactic dose is 600 microgram oral, whereas the treatment dose is 800 microgram sublingual. Okay, both have been asked. So it is important. 600 microgram oral in active management. So this is uterotonic. Next most important step is the controlled cord traction. Controlled cord traction has to be done only when there is a skilled birth attendant there, first thing, and one hand should always be on the fundus. Why? Because uterine inversion can happen. So one hand will be on the fundus and skilled birth attendant should always do the controlled cord traction. Last is uterine tone assessment. It is not massage. Uterine massage is not done once before the PPH has happened. This is all prophylaxis going on. If the PPH has not happened, you will not do the uterine massage. Uterine tone assessment is done. You will keep hand on uterus, and if it becomes atonic, then you will start the massage. Okay, right. Now delayed cord clamping, what about that? Delayed cord clamping is done in all the third stage of labor steps, whether it is expectant or active. Cord has to be clamped late, not before 1 minute. The purpose is for better neonatal health. It has nothing to do with PPH. It is not a step of active management. It is done in third stage of labor in everyone. Okay. Now the questions have been asked in multiple times on active management, just the options are changed. Like here, all are thus except control cord traction, early cord clamping, methergin or syntocinon. Obviously, early cord clamping. Next, what are thus except massage, control cord traction, oxytocin infusion or ergometrin. Uterine massage is not a step for active management, right? Yeah. One question was asked last year in NEET. In case the cord gets torn, what will you do now? In case your cord gets torn, it's fragile, it gets torn, then now you cannot do control cord traction. You have to do the manual removal. You have to insert your right hand inside the uterus, look for a plane between the placenta and the uterus and go in the slicing manner. With your left hand, you keep it on the fundus and try to direct fundus towards the right hand. That's what you do. You do not try to push your hands towards the fundus. You try to guide the fundus with your left hand towards the right hand so that the perforation does not happen. Okay, this is the method which you have to do in case you are asked detail. In case the cord gets torn, what do you have to do? Catheterize the bladder, massage the fundus. Important. Whatever method I am telling you of manual removal, it has to be done in OT with patient in general anesthesia so that uterus becomes relaxed. If it doesn't, you might have to give nitroglycerin. The question when asked about this, one option was Creedy's method. What is Creedy's method? In very preterm baby, very preterm IUD babies, the cord is not torn, but it is fragile. You know, if you will do traction, it will torn off. So you do in such a small babies, such a early preterm babies, you press the fundus. You press the fundus so that placenta can expel on its own. That is Creedy's method. Here you will not do Creedy's method. It's a full term, full grown uterus. You cannot compress the uterus here. So here manual removal is the answer. Right? Yeah. Now, prolonged labor. So question has been asked on the prolonged labor also in NEET 2019. Yeah. So in 2019, the definition of both latent phase prolong and active phase was asked. Latent phase prolong is more than 20 hours in primary, more than 14 hours in multi. That is prolonged latent phase. How do you manage? If the fetal condition, metal condition normal, you do not do anything. You just observe. Latent phase, don't do anything. Observe. If patient is very irritable with the pain, give her sedation. You do not do ARM, you do not do cesarean in latent phase. Latent phase cause no harm even if prolonged. It is important, it has been asked in NEET. Observe is your answer. Okay. Now, if prolonged active phase, first of all the definition. Now, active phase is the phase where actual descent of the head and the dilatation is occurring. So, it is described in that ways only. Protracted dilatation means less than 1.5 cm per hour in multi and less than 1.2 cm in primary. Is protracted dilation. Descent is 1 cm and 2 cm. You have to remember this number. No option. It has been asked in NEET 2019. Arrest disorder means no change is occurring. So when you say arrest, no change since 4 hours. This 4 hours is the reason that why active phase, alert line and active line on partogram are separated by 4 hours. Because if no change is occurring in 4 hours, you called it arrest and then you have to take some action. Okay. So this is the active phase. And how to manage active phase, that we'll see in partogram depending on the patient condition, how we will. Because if patient is in active phase and she is getting prolonged, you have to see why she is getting prolonged. You have to augment this labor. Augment means pain are there but they are not good. You want to give it a push. That is augment. So you have to augment this labor if it is getting prolonged in active phase. Okay. Partogram. Talking of prolonged labor, we have to discuss partogram. Almost 10 questions have been asked on partogram every year from NEET and INICET, one or the other way. So partogram, knowing partogram is extremely important for you. So this is partogram, what it is. It's a graphical representation of maternal and fetal condition against time. That's partogram. It carries 4 information. Fetal information, then rate of dilation and descent of head, that is cervicograph, uterine information and maternal information. These 4 things are discussed on partogram. Fetal information, you will plot fetal heart, which the normal is 160 by 110 here. This is normal. Anything beyond it is abnormal. So fetal heart has to be plotted every 30 minutes in low risk and every 15 minutes in high risk. In first stage, we know that it lies between 110 and 60. You have to mention amniotic fluid, clear, meconium stain for M, B for blood stain. Molding, you have to tell molding by +1 and +2. Anything beyond +2 in molding is a sign of CPD. If it is more than +2, it is +3. It means there is CPD. Your baby will not come out vaginally. Okay. Uterine contractions. Uterine contractions have to be plotted every 30 minutes. 1 block if you are coloring, it means 1 contraction. 2 you are coloring means 2 contractions in 10 minutes. Okay. And intensity, you will know by the method you are doing. If there are only dots, it's not a good contraction. If there are lines, it's a moderate contraction. If there is proper coloring, that might be translucent. If your whole box are colored, it is very good contractions. Adequate contraction of 40 to 45 seconds. Okay. So this is good contraction. That's what you have to mention. Cervicograph. Now cervicograph is part of partogram. It is telling you the progress of labor against time. That is cervicograph. How you started, everything in cervicograph is important. First, one small box. Yes, the question has been asked. Whatever line I'm saying, question has been asked on that. One small box is half an hour. So this box is 1 hour. Alert and action line are separated by 4 hours. Where do you plot? You start your plot on the alert line. Even if patient comes at 7 centimeter, your plot will be here. If she comes at 9 centimeter, this will be your plot, and from here you will start the time. You will never plot here. Your plot will be on the alert line. As soon as she crossed the alert line, it means her labor is not progressing normal. Now you have to intervene. Transfer her to a better center with good facilities. See the contraction, start oxytocin, rule out CPT. That's what you have to do. In case even after 4 hours there is a rest, there is no change. It means it touches the alert line. Here it crossed the alert line. Here it touches the action line. You have to do delivery. Either cesarean or forceps depending on the dilation and descent. That we will see in questions further. Okay, so this is how you plot. On the alert line it is started. So these are the information that every line has been asked in form of a question. How do you plot the descent of head? Descent of head is plotted how many parts are palpable per abdomen. So 3 by 5 is 3/5 part is palpable per abdomen. It means very high. 1/5 means 1 part of fetal head is palpable per abdomen. Rest is inside pelvis. So 1/5 means head is engaged. And 0 by 5 means head is deep into pelvis. Anything above 1/5 means your head is not engaged. If your head is not engaged, you cannot apply any instrument. And this all will decide how will you manage the labor further. Let's see some questions. A lot of questions have been asked on partogram. So there was partogram where you can see fetal heart is dropping significantly and your lines have crossed the action and alert line. It means you have to take a step. Can you see the contractions? There are 1, 2, 3, 4. 4 good contractions. Complete shading has been done. So oxytocin will not help. What will help? Forceps or cesarean. See the dilation. It is only 5 centimeter. You cannot apply instrument in 5 centimeter. Head is 3 by 5. So high. So forceps cannot be done. Your answer will be cesarean. So you have to see this for deciding what will be your next step. Here, fetal heart is normal. The line was like this. This year it was asked in NEET 2023. Line was almost reaching the action line. Contractions were good. Maternal condition was good. Now what do you have to do? It was here. Dilation was full centimeter. Full. Can you use instrument? Why not? See the descent. Descent was all through 3 by 5. It means 3 parts are palpable per abdomen. Only 2 parts have entered the pelvis. It is so high. It is not even engaged. You cannot use instrument. So here answer was cesarean. So that's how you have to see how do you manage based on a partogram. Okay. So this was all about normal labor. I have tried to cover all the questions asked in last 5 years. Next we will discuss the PPH and preterm in next lecture. Till then, bye bye.